What happens when a fracture is not safely tucked inside the body, when it is out there, exposed to the world, communicating with the environment? And what happens when a limb is so destroyed that the only logical choice is to remove it entirely? And when a patient has multiple injuries, fractures, and organ damage together, who takes priority, the patient or the bone? These three scenarios, open fractures, amputations, and polytrauma, are the backbone of emergency orthopedics. They show up in clinical practice and all over your exams, and they are deeply interconnected. By the end of this video, you will have a clear, confident understanding of all three, with every classification, every principle, and every MCQ pearl locked in. This one is for MBBS students, interns, and PG aspirants. Let us get into it. Let us start with open fractures, understanding exactly what they are and why they are dangerous. A fracture becomes an open fracture the moment the fracture hematoma communicates with the external environment. In practical terms, it is a fracture with a wound over it. That is your exam-ready definition. And why is this such a big deal? Two reasons. First, the fracture hematoma, which is the critical foundation of fracture healing, escapes out through the wound. Lose the hematoma, and you lose the biological scaffolding that drives healing. Second, and more dangerously, the reverse happens. The outside world gets in. Contamination. Infection. And when we talk about infection in any musculoskeletal structure, bone, joint, tendon, bursa, fingertip, the organism you should always be thinking about first is Staphylococcus aureus. It is the most common organism causing osteomyelitis, septic arthritis, tendon infections, bursitis, and open fracture infections. Burn that into your memory. Any MSK infection question, the answer is Staphylococcus aureus. When a patient with an open fracture arrives in the emergency room, your very first job is to classify the injury. The classification system you use is the Gustilo-Anderson Classification, and despite looking complicated at first glance, it breaks down very cleanly. There are three types: Type 1, Type 2, and Type 3. Type 3 is further divided into 3A, 3B, and 3C. Here is the key insight you need to hold on to. Wound size is the defining parameter for Type 1 and Type 2. But for all three subtypes of Type 3, there is a more important defining feature beyond just the size of the wound. Type 1 has a wound less than 1 centimeter. It is treated essentially like a closed fracture because the wound is so small and clean. Type 2 has a wound between 1 and 10 centimeters. Here, the size alone is what defines it. Now for Type 3, all three subtypes usually have wounds greater than 10 centimeters, but wound size is not the defining parameter anymore. Type 3A is defined by the environment the injury occurred in. Farm injuries, sewage contamination, gunshot wounds, high contamination environments. That is the defining feature of 3A. Type 3B is defined by periosteal stripping. The periosteum, the covering of the bone, has been torn away. The bone is bare and naked, completely exposed. This is significant because the periosteum carries blood supply to the bone. Strip it, and healing becomes much harder. Type 3C is defined by an associated vascular injury. An artery supplying the limb has been damaged. Now here is the clinical trap that gets students every time. Imagine a patient with a proximal tibia fracture with a 4 centimeter wound and a popliteal artery injury. What type is it? Most students see the 4 centimeter wound and jump to Type 2. That is wrong. The answer is Type 3C because the defining parameter for 3C is the vascular injury, regardless of the wound size. The size is secondary for Type 3. What matters is the defining parameter. 3A is contamination, 3B is periosteal stripping, and 3C is vascular injury. Now let us talk about how to actually manage an open fracture. There are two problems, the wound and the fracture. And between the two, the wound is more important. Stabilize the wound first. The fracture can wait a short while. Infection cannot. Step 1 is wound management. The moment the patient arrives, after standard first aid including anti-tetanus prophylaxis, you start broad-spectrum antibiotics immediately. Then you begin debridement. You clean out all dead, necrotic, and devitalized tissue until you reach fresh, healthy, actively bleeding tissue. Once clean, you wash the wound thoroughly with sterile normal saline, povidone iodine, or hydrogen peroxide. Now the question becomes, do you close it? Primary closure is acceptable only when all four of these conditions are met. The wound edges approximate easily. The wound is clean and neat. The wound is less than 6 hours old. This is the golden period of a wound, and there is no associated neurovascular injury. If any one of these conditions fails, if the wound is older than 6 hours, if the edges do not come together easily, if there is a neurovascular injury, or if you are not fully satisfied with your debridement, do not close it. Instead, opt for delayed primary closure. You repeat debridement once or twice over the next few days and close the wound only when you are confident it is clean and safe. The golden period of a wound is 6 hours. Beyond 6 hours, you assume the wound is contaminated. Step 2 is fracture stabilization. This is where things get important. You cannot use a plaster of Paris cast because there is a wound. The cast would trap infection. You cannot use internal hardware like plates, rods, screws, or nails at or near the wound site. Why? Because bacteria will colonize and grow on any foreign object placed in an infected or potentially infected environment. That is a disaster. So the only appropriate stabilization for an open fracture is external fixation. Here is how to apply that based on the Gustilo-Anderson type. Type 1. Treat it like a closed fracture. The wound is small. Type 3B and 3C. Always use external fixation, no exceptions. For Type 2 and 3A, if the wound is less than 6 hours old and your institution is well equipped, you can treat like a closed fracture. But if the wound is older, contaminated, or facilities are limited, go with external fixation. The overall strategy is elegant. Manage it as an open fracture temporarily until the wound heals. Once it heals, you convert your thinking. It is now effectively a closed fracture. Remove the external fixator, confirm there is no infection, and proceed to definitive fracture treatment. Now let us go deeper into external fixation, how it works, the devices available, and the complications to know. An external fixator stabilizes the bone from outside the body. You insert Schanz pins into the bone on either side of the fracture, away from the wound site. You then connect those pins to a rigid connecting rod using connectors. The rod immobilizes the pins immobilize the bone. Fracture stabilized, without a single piece of hardware anywhere near the wound. One of the most powerful devices in all of orthopedics is the Ilizarov ring fixator. Instead of pins and rods, it uses pins and circular rings. Beyond just stabilizing the fracture, the Ilizarov can compress, distract, or correct angular deformities with great precision. Its most important function is distraction osteogenesis, also called calotaxis. The principle is remarkable. You first cut the bone, a procedure called a corticotomy. You apply the Ilizarov frame. Then you very slowly distract the two bone ends apart. Bone, remarkably, regenerates in the gap that is created, forming new healthy bone through the process of distraction. The critical number you must remember is that the rate of distraction must not exceed 1 millimeter per day. This is the physiological limit. Exceed it, and the bone will not form properly. Respect it, and you can grow centimeters of new bone. The Ilizarov technique is indicated for open fractures, infected fractures, and osteomyelitis, non-union and malunion, fractures with bone loss, deformity corrections, and limb lengthening. There is also a modification called the Limb Reconstruction System, or LRS, also called the rail fixator. It uses pins connected to blocks that slide along a rail. It can compress or distract just like the Ilizarov, but has a simpler, more modular design. This has been asked in AIMS examinations. Now for the most common complication of external fixation, ring sequestrum. When you drill a Schanz pin into bone, the drilling generates heat. This heat causes necrosis of the bone around the pin insertion site. Dead bone at a pin tract site takes the shape of a ring, hence ring sequestrum. It can also occur due to direct pin tract infection. Either way, ring sequestrum means dead bone at a pin insertion site. Now, regarding stability of external fixators. To make an external fixator more stable, you can increase the number of pins in the bone, increase the number of rods connecting the pins, or increase the number of planes. Going from uniplanar to biplanar to multiplanar increases stability. The stability ranking from lowest to highest is uniplanar single rod at the bottom, then uniplanar double rod, then biplanar, and at the top, the Ilizarov ring fixator, which is multiplanar and the most stable. Sometimes a limb is so severely damaged that no amount of surgical skill will save it, and attempting to do so will only waste time and resources while the patient deteriorates. In those cases, amputation is the correct decision. But it cannot be a subjective call made on gut feeling. We need to be objective. To keep the decision objective, we use scoring systems. The primary one is the MES score, the Mangled Extremity Severity Score. The MES score looks at 4 parameters. The velocity of injury, whether it was low, medium, or high energy. The ischemia of the limb. This is the most important parameter, and critically, if the ischemia time exceeds 6 hours, the score is automatically doubled. The shock status, the patient's hemodynamic stability, and the age of the patient. Older patients score higher. If the MES score is 7 or more, amputation is indicated. Other objective tools you should know are the Limb Salvage Index and the Ganga score. Now, all indications for amputation can be grouped under 3 categories, the 3Ds. The first is a dead limb. The limb has no viable blood supply. Examples include peripheral vascular disease and crush injuries. The second is a dangerous limb. The limb poses a threat to the patient's life if kept. Gas gangrene is a classic example. The infection will kill the patient if the limb is not removed. Malignant tumors of the limb also fall here. The third is a dumb limb. A useless, functionless limb that the patient cannot use, and that serves no purpose. This includes limbs with severe congenital deficiency or catastrophic neural injury with no chance of recovery. An important MCQ distinction. The most common indication for amputation worldwide is peripheral vascular disease, particularly in diabetic patients. But in India, the most common indication is trauma, specifically crush injury. Regarding the type of amputation, closed or open. A closed amputation, also called a primary amputation, is used for clean wounds in trauma cases where there is no infection. The skin is closed in the same surgery. An open amputation, also called a guillotine amputation, is used when there is infection or ischemia. The stump is left open, and closure happens only in a second surgery after the infection clears. Now let us go through the surgical principles of performing an amputation, the key technical decisions that define whether the outcome is good or bad. The first principle is tourniquet use. A tourniquet is applied proximal to the surgical site to create a bloodless field in most amputations. But there is one important exception. Do not use a tourniquet when the indication for amputation is ischemia or peripheral vascular disease. In those cases, you need to see fresh, healthy bleeding at the level of amputation to confirm that the tissue there has adequate blood supply. A tourniquet would mask that completely, and you might end up cutting at a level where the tissue is also ischemic and will not heal. The second principle is the distinction between amputation and disarticulation. An amputation means the limb is divided through the bone. The bone itself is cut. A disarticulation means the limb is divided through the joint. The bone is not cut at all. This distinction is a very frequently tested MCQ. Amputation through bone. Disarticulation through joint. The third principle is stump closure, myodesis versus myoplasty. Myodesis means the residual muscle is sutured directly to bone. This is the preferred technique in most amputations because it creates a stable, firm stump that works well with a prosthesis. Myoplasty means the residual muscle is sutured to the opposing muscle, muscle to muscle, not muscle to bone. This is used specifically when the indication for amputation is ischemia or peripheral vascular disease. Why? Because in an ischemic limb, the muscle is already poorly perfused. Suturing an ischemic muscle to bone, which is also relatively less vascular, makes no sense. Instead, you suture it to the opposing muscle, which has a better blood supply, and this encourages recovery. So myodesis is preferred in most cases. Myoplasty is used for ischemia and PVD, and myodesis is contraindicated in ischemic amputations. The fourth principle is bone length. The bone must always be cut 5 centimeters shorter than the surrounding soft tissue. This ensures there is enough soft tissue to cover and close over the stump without any tension on the wound. The fifth principle is skin flap design, skewed versus symmetrical. In a symmetrical flap, the anterior and posterior skin flaps are of equal length. When they come together, the suture line sits right at the bottom of the stump, directly under the prosthesis. Every step, that suture line gets compressed, causing pain and wound breakdown. In a skewed flap, the posterior flap is made longer than the anterior flap. When they come together, the suture line ends up anteriorly, in front of the mid-coronal plane of the stump. It is away from the weight-bearing surface entirely. The patient can walk without the suture line being under pressure. The skewed flap is preferred. The symmetrical flap is not preferred. Simple concept, very frequently asked. Now let us go through the complete terminology of amputations. Upper limb first, then lower limb. These names describe the level at which the amputation is performed, and you need to know them cold. Starting with the upper limb, from proximal to distal. Forequarter amputation goes through the shoulder girdle itself. The entire upper limb, including the clavicle and scapula, is removed. This is the most radical upper limb amputation. Shoulder disarticulation is performed at the glenohumeral joint. Transhumeral amputation, also called mid-arm amputation, cuts through the shaft of the humerus. Elbow disarticulation is at the elbow joint. Forearm amputation goes through the bones of the forearm, the radius, and ulna. Wrist disarticulation is at the wrist joint. Ray amputation removes a full digit along with all its proximal structures, the entire ray. And then there is Kruck-Hinberg amputation, which deserves special attention. This is a forearm amputation where the radius and ulna are separated and used as a functional pincer, essentially like a crab claw. It has a very specific and important indication. It is used in blind amputees to restore grip. A blind person cannot use a standard prosthetic hand effectively because they rely entirely on sensory feedback. With a Kruck-Hinberg amputation, the two bone segments retain their sensation and can grip objects. Very unique concept, very frequently asked. Now for the lower limb, from proximal to distal. Hindquarter amputation, also called hemipelvectomy, goes through the hemipelvis. The entire lower limb along with part of the pelvis is removed. Hip disarticulation is at the hip joint. Transfemoral amputation, or above-knee amputation, goes through the femur. Knee disarticulation is at the knee joint. Transtibial amputation, or below-knee amputation, goes through the tibia. This is the most commonly performed amputation overall. Remember this, transtibial is the most common. Also note that below-knee amputations are contraindicated in diabetic patients because of poor vascularity of the distal stump. Symes amputation is 0.6 centimeters above the talar dome at the ankle level. Chopar's amputation goes through the talonavicular joint and the calcaneocuboid joint, the mid-tarsal joint. Lisfranc's amputation goes through the tarsometatarsal joint. One more worth knowing is the Gritty-Stokes amputation, performed at the distal femur. After removing the distal femur, the patella and its soft tissue are used to close the stump. It creates a practical, load-bearing stump. 4 important hindfoot amputations share a common story. Each was designed to improve on the previous one by saving more limb length. Let us go through them in sequence. Symes amputation is performed 0.6 centimeters above the talar dome. The medial and lateral malleoli are retained. This gives a very wide base to the stump, but that wide base is actually a problem because it is too wide for comfortable prosthetic fitting. Sarmiento's amputation is a modification of Symes. It is performed 1.3 centimeters proximal to the talus. The malleoli are also removed this time, producing a narrower base. Better for prosthetic fitting, but it removes slightly more of the limb. Boyd's amputation takes things further. Everything distal to and including the talus is removed. The calcaneum, the heel bone, is then fused directly to the tibia. This procedure is called tibiocalcaneal arthrodesis. It preserves more height than Symes in some respects, but still sacrifices significant limb length. Pyrogov's amputation is the modification of Boyd's. After the talus is removed, the talectomy, the calcaneum is not simply fused in place. It is cut and rotated before being fused to the tibia. This rotation is the key difference from Boyd's, and it preserves maximum limb height. The goal of each successive modification is the same: save every centimeter of limb length possible. Now, why does limb length matter so much? The answer is energy expenditure. Every centimeter of limb you preserve is energy the patient saves for daily activity. At the level of knee disarticulation, the patient expends approximately 50% more energy to walk than a person with a normal limb. At the level of hip disarticulation, the extra energy required doubles, 100% more. This is why we fight for every centimeter of length. Preserving limb length serves two purposes: energy conservation and better prosthetic fitting. Like any surgery, amputation has its complications. The standard ones, infection, bleeding, and flap necrosis, are always possible. Flap necrosis in particular can happen when the sutures at stump closure are too tight, cutting off blood supply to the flap edges. But the two complications that are unique, high yield, and frequently tested are amputation neuroma and phantom limb sensation. Let us start with amputation neuroma. When a nerve is cut during amputation, the proximal segment does not simply stop. It produces axonal sprouts, bundles of naked, hypersensitive nerve endings that form a painful nodule called a neuroma. If the nerve is cut improperly, for example, just at the surface, this neuroma forms right at the stump edge where it will be compressed every time the patient wears a prosthesis. The result is severe, debilitating pain. The correct technique to prevent this is simple. You pull the nerve taut, then cut it cleanly with a fresh sharp blade. When you release the nerve, it retracts deep into the tissue. So even if a neuroma forms over time, it is safely buried deep and not at the surface where it would be compressed. If a neuroma does form and causes pain, the best treatment is surgical excision. You identify the neuroma, pull the nerve out, and recut it properly. If surgery is not possible, the non-surgical option is TENS, transcutaneous electrical nerve stimulation, which is preferred over interferential therapy. Now for phantom limb sensation. A patient who has had a limb their whole life will, after amputation, feel that the limb is still attached. They may feel the shape of the fingers, pain in the toes, sensation in the foot, even though nothing is there. This is phantom limb sensation. It is not pathological, it is expected, but it can be very distressing. There is an important distinction here. Phantom limb sensation does not occur in patients who were born without a limb, patients with congenital limb absence. They never had the limb to begin with, so there is no neurological memory of it. The sensation resolves progressively over time, and it resolves from distal to proximal. The patient stops feeling the toes first, then the foot, then the ankle, gradually moving upward. This pattern of resolution is called telescopic relief. A prosthetic limb has three main components: the socket, which is the most important part because it interfaces directly with the stump, the connecting rod, and the terminal device, which is the foot. Two terminal devices are high yield for your exam: the SAC foot and the JIPER foot. SAC stands for solid ankle cushion heel. The defining feature of this prosthetic foot is that the ankle, also called the keel, is completely rigid and solid. There is no movement at the ankle at all. No dorsiflexion, no plantar flexion, no inversion, no eversion. The heel is cushioned to absorb some shock, but that is it. Because there is no ankle motion, squatting is not possible. Walking on uneven surfaces is poor. And the SAC foot is not designed for barefoot use. It is a Western design, and it is expensive. Now the JIPER foot. This was designed in India by Dr. P.K. Sethi, specifically for the Indian population. The ankle is flexible and allows the full range of motion: dorsiflexion, plantar flexion, inversion, and eversion. Because of this, squatting is possible. Walking on uneven terrain is excellent. The JIPER foot is waterproof, and it looks like a natural foot, making barefoot use entirely possible. And it is significantly cheaper than the SAC foot. Why does this specifically matter for the Indian population? Because squatting to use toilets, walking barefoot inside homes and temples, and navigating uneven rural terrain are everyday necessities for a huge proportion of Indian patients. The SAC foot cannot accommodate any of these activities. The JIPER foot was designed precisely to address these needs. So for the Indian population, the JIPER foot is the clear preference. This is a very commonly asked exam question. The reasoning is socio-cultural and functional, not just technical. Amputations in children follow different rules than in adults, and the key reason is the growth plate. Children are not small adults. The principles are different. The most important principle is this: in children, disarticulation is always preferred over amputation. Here's why. The growth plate, also called the physis, sits at the distal end of the bone. If you perform an amputation through the bone, you remove the growth plate, and longitudinal bone growth stops permanently at that level. As the child grows, this creates increasing problems. the residual limb falls further and further behind in length compared to the other side. But if you perform a disarticulation through the joint, the growth plate is preserved and the bone can continue to grow normally. This is critical in a growing child. The second important point is that stump revisions are expected in children. As the child grows, the residual limb changes in length relative to the rest of the body, and the stump needs to be surgically adjusted periodically. This is not a complication. It is a predictable, planned part of long-term management. Families must be counseled about this from the very beginning. And third, children adapt remarkably well to prostheses. Unlike adults, who often struggle with the psychological and functional adjustment, children are flexible and resilient. They redesign their lives and activities around the device and often achieve very high levels of function. The long-term prognosis for a well-managed amputation in a child is actually quite good. When a traumatic amputation occurs and conditions are right, reimplantation, surgical reattachment of the amputated part, is possible. Two prerequisites must be met. The wound must be clean and the MES score must be low, indicating the part is still viable. Transporting the amputated part correctly is critically important, and this exact sequence is asked in exams. First, clean the amputated part in sterile normal saline or Ringer's lactate. Second, wrap it in sterile gauze that is soaked in normal saline or Ringer's lactate. Third, place the wrapped part in a sealed plastic bag. Fourth, place the sealed bag in ice. Not directly on ice, the part must stay dry. And fifth, transport to hospital as quickly as possible. The key principle is that the part must be kept cool, but not wet. Direct contact with ice causes cold injury to the tissue, which is why it goes in a bag first. Now, when reimplantation is performed, there is a specific order in which structures are repaired. This order is remembered by the mnemonic. B fan of Verinder Sevog. B is for bone, repaired first. E is for extensor tendons. F is for flexor tendons. A is for artery. N is for nerve. V is for vein. And S is for skin, repaired last. Bone is always repaired first because it provides the rigid structural scaffold for everything else. Without bone stability in place, suturing delicate tendons and vessels is far more difficult. You build the frame first, then you fill it in. Now we move to polytrauma, the scenario where a patient has multiple injuries at once. A polytrauma patient is defined as someone who has fractures plus injuries to two or more organ systems. For example, a fracture combined with a head injury, a chest injury, or an abdominal injury. Managing this patient requires a structured, prioritized protocol, and that protocol is ATLS, Advanced Trauma Life Support. But first, a very common source of confusion needs to be cleared up, the difference between CAB and ABC. CAB stands for compressions, airway, breathing. It is used in basic life support and advanced cardiovascular life support, meaning it is for the cardiac arrest patient. Someone with no pulse, no blood pressure, who needs to be resuscitated. Compressions first to get blood moving. ABC stands for airway, breathing, circulation. This is the ATLS sequence, used for the trauma patient who is alive but critically injured. These are entirely different patients with entirely different priorities. BLS is for cardiac arrest. ATLS is for the trauma patient who is injured but not in cardiac arrest. Now, in trauma, deaths occur in a trimodal pattern, 3 peaks. The first peak is immediate, occurring within seconds to minutes at the scene. These deaths are caused by massive head injuries or catastrophic vascular injuries. There is nothing medicine can do for these patients once the injury happens. Prevention is through education, helmets, seatbelts, road safety. The second peak occurs within the golden hour, the first 60 minutes after injury. These deaths are caused by treatable conditions, tension pneumothorax, hemothorax, and cardiac tamponade. These are rapidly fatal, but also rapidly reversible if caught fast. This is exactly the peak that ATLS is designed to prevent. The third peak occurs days to weeks after the injury, caused by sepsis and multi-organ failure. This is partially preventable through good ICU management. ATLS targets the second peak. That is its entire purpose. The ATLS protocol follows the ABCD sequence, and you address problems in this exact order, from the most immediately life-threatening to the least. A is airway with cervical spine stabilization. Secure the airway first. using chin lift or jaw thrust maneuver, and simultaneously apply a Philadelphia collar to protect the cervical spine. Without an airway, the patient dies in seconds. The spine protection matters because a trauma patient may have an unstable cervical injury, and any unguarded movement could convert an incomplete cord injury into a complete one. B is breathing and ventilation. Once the airway is secure, confirm that air is actually moving in and out. Check for chest expansion. Look for and manage tension pneumothorax, open pneumothorax, massive hemothorax, and flail chest. Without breathing, the patient dies in minutes. C is circulation with hemorrhage control. Address all bleeding, external and internal. 2 large-bore intravenous lines, fluids, and blood products. Think about where the patient might be bleeding internally. Without circulation, the patient dies in minutes to hours. D is disability, meaning neurological status. Assess the Glasgow Coma Scale, pupil responses, and limb movement. This identifies brain injury and gives you a baseline. E is exposure and environment. Cut all clothes off and fully expose the patient to find every injury. Then immediately cover the patient to prevent hypothermia, which is one of the deadly triad in trauma along with acidosis and coagulopathy. Now here is the most important MCQ trap around ATLS. They will give you a scenario, a polytrauma patient with active bleeding from the femur and open wound on the leg. The patient is screaming and in pain, and ask what the first step is. The emotional pull of the scenario makes you want to control the bleeding. The answer is still airway with cervical spine stabilization. Always. No matter how dramatic the scenario. No matter how much blood you see. The protocol does not change based on how the question is framed. Airway first. Always. When we reach the circulation step, the C in ATLS, the most common source of internal bleeding in polytrauma is a pelvic fracture. Why? The pelvis is a flat cancellous bone surrounded by an extensive venous plexus. When it fractures, you get bleeding simultaneously from the cancellous bone surface and from ruptured pelvic vessels. The pelvic cavity can accommodate enormous volumes of blood before it becomes apparent externally. The expected blood loss from a pelvic fracture is 1.5 to 2 liters, roughly 4 to 8 units of blood. This alone can cause hemorrhagic shock. There are 3 steps to control pelvic fracture bleeding, in order. First, wrap the pelvis. Using a pelvic binder, a bed sheet, or a blanket, you compress the pelvis from the outside. This creates what is called pelvic tamponade. By reducing the pelvic volume, you slow the bleeding. This is the first thing you do. Second, give intravenous fluids. Ringer's lactate is the preferred fluid in ATLS because it has a buffering effect on the metabolic acidosis that develops in trauma. Third, apply an external fixator in compression mode. This compresses the pelvis mechanically, further reducing pelvic volume and adding to the tamponade effect. The MCQ pearl here. Pelvic fracture is the most common cause of internal bleeding in polytrauma. The first step is always to wrap the pelvis, and the expected blood loss is 1.5 to 2 liters. When transporting a polytrauma patient, there is a correct and specific technique. Place the patient on a hardboard or rigid stretcher in the supine position. Secure the patient with belts so they cannot roll off during movement. When you need to turn the patient to examine the back, for example, you use the log roll technique. This means turning the patient as a single rigid unit, without allowing any twisting of the spine. The log roll requires a minimum of 4 people to perform safely, 3 to roll the patient, and 1 to support and control the head and neck. Now let us talk about damage control orthopedics, one of the most important conceptual principles in polytrauma management. The core principle here is straightforward. The patient is more important than the fracture. New residents sometimes become so focused on reducing and fixing fractures that they proceed to lengthy definitive orthopedic surgery on a patient who is simultaneously bleeding out, coagulopathic, or in severe metabolic shock. Damage control orthopedics is the antidote to that tunnel vision. The DCO approach says, in a critically ill polytrauma patient, do the minimum necessary to control hemorrhage and contamination right now. Stabilize the fractures temporarily using external fixation. Then send the patient to the ICU for resuscitation and full physiological stabilization. Only once the patient is optimized, the bleeding stopped, the coagulopathy corrected, the physiology normalized, Do you proceed to definitive fracture fixation? The specific indications where you must use DCO and must not go for definitive surgery include fat embolism syndrome, severe chest injury, coagulopathy, hypothermia, and severe acidosis. In any of these situations, a long definitive orthopedic procedure will likely kill the patient. DCO keeps them alive. Crush syndrome is what happens when a limb is trapped under a heavy object for a prolonged period, a collapsed wall, a vehicle, a machinery accident. Here is the sequence of events. The compression cuts off blood flow to the muscle, ischemia. The muscle cells begin to die, myonecrosis. When the rescuers arrive and the crushing force is removed, blood flows back into the damaged tissue, reperfusion. That reperfusion is where the systemic problem begins. The dying muscle cells have been accumulating toxic metabolites. When circulation is restored, those metabolites flood into the systemic circulation. The most dangerous of them is myoglobin, a protein released from destroyed muscle cells. Myoglobin is directly toxic to the renal tubules, causing acute tubular necrosis and acute kidney injury. The systemic manifestations of crush syndrome are important to know. Metabolic acidosis develops from the accumulation of anaerobic metabolites during the ischemic period. Hyperkalemia results from potassium released from destroyed myocytes. This alone can be immediately life-threatening, causing fatal cardiac arrhythmias. Hypocalcemia occurs because calcium deposits in the damaged tissue. An acute tubular necrosis follows from the myoglobin toxicity on the kidneys. Treatment is directed at one goal: flush the toxic metabolites out of the body before they cause irreversible renal damage. The two pillars of treatment are aggressive intravenous fluid therapy, using Ringer's lactate or normal saline to force a high urine output and wash the myoglobin through, and alkalinization of the urine using sodium bicarbonate. Alkalinizing the urine changes the chemical environment in the tubules and reduces myoglobin precipitation, protecting the tubular cells. Before we close, there is a critical misconception about compartment syndrome in open fractures that needs to be addressed directly. Many students assume that if there is a wound over the fracture, the compartment is decompressed and compartment syndrome cannot occur. This is completely false. A skin wound does not open the deep fascia. The muscle compartments remain enclosed even when there is a wound on the surface. Compartment syndrome can and does occur in open fractures. You must maintain a high index of suspicion, particularly in patients with altered consciousness who cannot communicate their pain. The normal intracompartmental pressure is less than 10 millimeters of mercury. Compartment syndrome is diagnosed when pressure exceeds 30 millimeters of mercury. In unconscious patients where you cannot rely on clinical signs, use a manometer for objective measurement. And when compartment syndrome is confirmed, the treatment is emergency fasciotomy, surgical release of the compartment. The most commonly involved bones in open fractures, worth knowing, are the tibia and the phalanges. Now the outro. From the moment an open fracture communicates with the environment, to the decision to amputate a mangled limb, to managing a polytrauma patient whose life hangs in the balance. Every decision in emergency orthopedics follows a clear logic. Wound before fracture. Patient before bone. The most immediate threat first, always. The Gustilo-Anderson Classification tells you how dangerous the fracture is. The MES score tells you whether to salvage or amputate. The ATLS protocol tells you what to do and in what order when everything is wrong at once. Master these frameworks, and you will never be lost in a clinical viva or an exam. If this helped you, drop a comment and let me know what topic you want covered next. Like, subscribe, and share this with your batch. Good luck, and stay curious.